Greetings, everyone. We would like to welcome you to our live webinar presentation, Putting the Ethical Guidelines for the Use of SDOH into Practice. Today's webinar is co-sponsored by LexisNexis Healthcare. If you were on an airplane right now, you'd need to listen to some safety instructions before the plane takes off. So buckle up, and please pay attention to these brief items of note before our webinar takes off today. During the webinar, all attendee lines will be muted. To ask speakers a question, on the left-hand corner of your screen you'll see a blue Ask a Question box. Simply type in your question and press Send. If you need any assistance during this webinar, please contact our Health Web Summit office at 209-577-4888. A cross-country collaboration led to the publication of guidelines to drive the ethical use of social determinants of health. Patients are people first, and treating them holistically requires the use of insights derived from both clinical and non-clinical data. When these data sets intersect and the insights are used to drive meaningful conversations with patients and reduce barriers to care and wellness, we all win. During today's webinar, you'll hear from several of the organizations who collaborated on the guiding principles for the ethical use of social determinants of health. Our speakers are Jennifer Kovich-Bordenick, Karin von Zont, and Aaron Benson. Jennifer is the Chief Executive Officer with eHealth Initiative and Foundation. For over 20 years, Jennifer has focused on quality and innovative technology solutions to transform healthcare. As CEO, she provides leadership for research, education, and advocacy components of eHealth Initiative and Foundation, convening senior executives from every group of healthcare to discuss, identify, and share best practices that transform the delivery of healthcare. Karin von Zont is the Vice President of Integrated Community Partnerships at CareSource. Since 2015, Mrs. von Zont oversees the work of social determinants of health at CareSource and the full integration into the population health model. Aaron Benson is the Director of Market Planning for LexisNexis Risk Solutions Healthcare. Ms. Benson focuses on the development and execution of strategic planning for identity management and social determinant of health solutions. She came to LexisNexis from Deloitte Consulting. So, without further ado, our speakers are now ready to begin.
Hello, everyone. Thank you for joining today's webinar, Putting the Ethical Guidelines for the Use of SDOH into Practice. My name is Charlene Serrano with LexisNexis. As today's moderator and on behalf of LexisNexis Risk Solutions, I welcome you to today's program. This is an interactive event. Feel free to submit questions to our speakers through the Q&A widget on your screen. We will use the last 5 to 10 minutes of the webinar to answer any questions you may have. Now, without further ado, I would like to introduce our first speaker, Jennifer Kovich-Bordenick.
Hi, everybody. This is Jen Kovich-Bordenick from the eHealth Initiative. We're really delighted to have you here today to talk about social determinants of health and the ethical guidelines that we developed. I want to talk a little bit about this collaborative project that we kicked off this year with the eHealth Initiative and LexisNexis and a number of other organizations as well, looking at the ethical use of social determinants of health. And SDOH has been around for a while. I think people in public health will tell you that these have always been important factors in terms of thinking about people's outcomes and health and well-being. But in terms of using social determinants of health as a key factor and variable in healthcare is not something that we have looked at in terms of pulling data and doing targeted analysis and thinking about it in terms of actual clinical outcomes. So it's been on the hype cycle, if you will, over the last couple of years across the nation here. And there's been, I'm sure you've seen lots of reports and press articles and interviews and all kinds of things where people are talking about social determinants of health and how important they are and how you can use them in analytics. But one of the things that people hadn't really been talking about was what is really kind of the best way to use this data in healthcare? When is it appropriate? What's the right way to use it? So we started to convene a group to look at those aspects and think about SDOH, which is the acronym for Social Determinants of Health, in a different way. And eHealth Initiative was the organization to convene this collaborative project. For those of you who don't know the eHealth Initiative and our foundation, we're an organization, a nonprofit, and we convene executives from across the spectrum of healthcare to look at key issues like social determinants of health, sit down and figure out, how can we use this new technology and information in healthcare to really improve care for patients. And that's what we did with this project. And as I mentioned, we pulled together organizations from across the spectrum of healthcare, so labs, vendors, providers, payers, consumer groups, of course, patient advocacy groups, researchers, all different groups, to think about what are kind of the important core elements of social determinants of health. And this is just an example of some of the groups that were involved in this initiative and many others. And I'll get more specific about this as we go through here. So one of the things about social determinants of health, and as I mentioned before, we've always kind of known that these different factors are important and impact healthcare. So here are just a couple of examples. Say you've got individual Sally, and she can't get to her doctor because she doesn't have a car, she doesn't have reliable transportation. So transportation issues are a big factor across the country, and actually 17% of folks around the country do have transportation issues when it comes to getting to their doctor. About 21% of folks have to prioritize their rent and groceries. They don't have the funds and the money that they need really to afford doctor's visits and prescriptions. 13% of the nation deals with caregivers, not having a caregiver or having nobody really to assist them when they are sick. So people who are virtually alone and have no one to rely upon when they're sick. And then 9% of the nation who isn't able to see their doctor because of not home issues. So maybe they're homeless or in between homes or have issues around home security, as we call it. So when we think about what are social determinants of health, so social determinants of health are kind of all of those factors around us which impact how people, their health, their functioning, and their quality of life. So things that have to do with where people are born, where they live, how they learn, how they're educated, where they play, where they worship, the age that they are, all of these different factors that we didn't normally think about regularly in terms of healthcare information and the medical record and in the traditional form of healthcare. So it's only most recently that a lot of organizations are trying to figure out how do we pull all of these important factors into the healthcare equation and try to impact some of them to improve health. So things like economic stability, education, your social and community context, your health and your healthcare. All of these things we know are very, very, very important as we go through. So we've started to realize, I think, in the last couple of years, payers and providers, and I think providers, if you talk to clinicians, they say, well, we always knew this was important. We just didn't have a way necessarily to reach out and use the community resources or access resources that we could get to help patients. I think, in hospital environments, you've got social workers who have usually been relegated to work on these issues, or social service agencies, which generally dealt with these issues. And now we're trying to figure out, what are those issues that really impact the patient and is actually impacting the patient's outcomes. So pairing medical care with these social determinants of health, I think we've found in research, we know in research, can significantly improve care, lower cost, and improve quality of life for millions. With our collaborative, we actually looked at a lot of research. We heard from a number of different experts around the country, and I think it's really undeniable that social determinants of health can significantly improve care and lower cost. This really isn't an argument anymore. We don't need to argue that it's important to address these factors. We just need to figure out what's the most appropriate and the best way to do it and the ethical way to do it to incorporate these factors into health care. But there's no longer really an argument that these factors do, in fact, impact care. So given that everybody has kind of recognized and the research has pointedly confirmed that using social determinants of health data in healthcare can improve costs and improve care and outcomes, we decided, let's talk about this. Let's figure out how we could do this with providers and payers and vendors alike. And one of the things that we said, what's the right way to do this? We realized we initially thought we were talking about kind of the appropriate use of social determinants of health. And we came to realize we were actually talking about the ethical use of social determinants of health. Because what we're really talking about is when is it kind of right to use this stuff, and when are we kind of out of bounds in terms of ethics around using this stuff. Because this is very personal and sometimes sensitive data, and it really needs to be used, I think, in an ethical way. So we had several different meetings, and this is a list of some of the key participants who participated in this specific collaborative. A number of different organizations you can see that really helped in terms of crafting the principles that we came up with. And I'm really proud of this list, and I know that we always forget or leave somebody off the list. So let me just apologize in advance if your name's not on here. I'm sure, as I mentioned earlier, there are a lot of organizations that participated in this. But this was a really difficult issue, and we had a number of different discussions trying to figure out what is really ethical around using this. And as I mentioned, the purpose was really to help guide the healthcare industry in terms of clearly articulating what is the ethical use of this data, and help the healthcare industry as it transitions to understand how to use this data. And to kind of kick off the development of some policies and procedures related to the collection of this data around the industry. Because I think we really do need some standards for collecting and protecting this data and make sure there's proper governance, data governance. We need to be accountable for this data, and we need to be able to, determine, are people using this data in an ethical way and is an effective way? And evaluate that in some sort of way that we can look back later on and say we did this right. So the ethical use of guidelines. So the ethical use of social determinants of health data is really predicated on improving the health of individuals and providing the right interventions and the services at the right time. And our hope is that by using social determinants of health, we can catch folks, prevent things from happening later on, and really improve care overall. So we came up with these principles, and I'm going to walk through these principles and give you kind of a series of examples so you can help understand them. I do want to let you know, and Erin, perhaps we could send out the link to download. There's a full report or brief that outlines all of these in much greater detail and a number of resources, and we'll send that out to the group here today so you can go ahead and download those. But there's a background paper, there's a brief, there's a press release, there's all kinds of resources that you can tap into to get more detail on this, because we're not going to be able to get into major detail on this today, but we'll get as far as we can get here. So the first principle is really around care coordination. So let's just think of an example here. So imagine a doctor tells a patient that the patient should really be eating a full breakfast every day before they take their prescription. And the doctor comes to realize, you know what, the patient maybe isn't eating a full breakfast or doesn't have access actually to the food or the types of food that they need. So a doctor might share information about a food bank or help connect that patient to resources either in the community or help direct them to an agency or a group that can help them with food insecurity issues. So that's kind of an example of care coordination. So part of the care coordination principle really has to do with the fact that we want to identify individuals who have social determinants of health needs, for example, like food insecurity, and then help coordinate and deliver more holistic care, and help facilitate connections to additional interventions or services, of course, always keeping top of mind their privacy and security protections. I mean, and this is really the whole idea that, if you can recognize issues early around food security or transportation or housing, if you have that information up front, providers and community and agencies can really help connect people and make it part of their personal care plans to ensure that patients really have what they need to not just to improve their health outcomes, but really to get the quality of life that they need and improve their care overall. The second principle I want to walk through here is something called recognizing risk through social determinants of health or analytics. And this is actually something I think that we hear about a lot. And let me just talk you through this a little bit. So this is actually identifying patients who might be at risk through the use of analytic tools in order to develop population health management interventions for individuals and communities. And the whole idea behind this with the social determinants of health is that we have all of these great population health interventions and programs and things, and we know that there's a need out there. So when you do have those programs and interventions available, the idea is to identify folks who might be at risk for those things and who could benefit from those interventions and connect them to those interventions. So for example, perhaps you have a new OB patient who doesn't have a support system. This might be where a doctor knows that there is an intervention in place for new mothers or a maternal care intervention, population health program perhaps to help, and this is where you might use an analytics tool to identify pregnant mothers who could possibly benefit from that intervention. So it's using social determinants of health really to identify folks who could benefit from an intervention. And this is actually closely tied to the next principle, which is mapping community resources and identifying gaps. So assessing individual social determinants of health needs against available community resources to identify gaps that address health and wellness. And this is really understanding that there need to be, oftentimes there are community resources available for patients that it's just a matter of kind of letting providers know and helping providers know how they can access those resources, or rather how their patients can access those resources. So it's all about kind of this matchmaking or connecting patients to resources available in their communities and helping providers understand what is available out in the community and helping patients and individuals understand what resources are available to them out in the community. So an example here is perhaps if you have a patient at your clinic that's newly homeless, maybe they're schizophrenic, the doctor could share programs and support groups that the community has available. So it's making sure that clinicians in their offices know these are the resources that are out there in the community for you. You know, we hear so often from providers, yeah, I know that, you know, some of my patients are homeless or they have food issues or transportation issues, but I don't have time to deal with that. I don't know how to handle that. So this is a matter of connecting the resources at the point of care where it's identified that this might be an issue or a problem. So it's helping to make those connections and mapping resources and helping to identify gaps. The next one here is about service and impact assessment. So the whole idea here is that it's really important not just to have these programs out there, but to measure them and assess whether or not they're effective. So assessing the impact of social determinant of health interventions and services. So it's always having kind of that feedback loop. You know, stakeholders really have to be measuring and monitoring these interventions out there and ensuring that they correlate to better health outcomes. You know, we don't want to just be directing patients to programs and not knowing if they work or not, or interventions that we know are not effective. We want to make sure that these things are actually working for the patients, that patients were connected to them. So you really need to have in place some kind of standard process in place for tracking the outcomes of any referrals that you make or connections that you make for these patients. So these processes are really needed. So there has to be better coordination between some of these social service agencies or whatever community resources are available and some sort of feedback loop to know that these are actually effective interventions and services. So the example here would be perhaps, an individual has transportation issues. So perhaps a doctor recommends a new Uber service. I think this is the example we hear a lot. That there are all of these transportation services available to get people to appointments and treatments, et cetera. So does that really work? We know that oftentimes patients are referred and use these interventions to get to appointments and treatments. When we look at some of these things, we find that they're actually not working because perhaps there's another issue that's come up that's the real heart of the matter. So understanding, does that connection to that resource actually improve the outcome, actually help the patient with the issue that they had initially, or is it another issue? Is it an issue having to do with child care, or is it an issue having to do with something else? So I think, really doing kind of the follow through and understanding, is the intervention that we put in place to assist this person actually addressing the problem at hand? And I think that that's really important, particularly around the transportation issue, because I think there are a lot of examples where we quickly assign a solution to something that might not necessarily get at the heart of the matter. So I just want to bring that up there. And then finally, I think the last principle here is around customizing health services and interventions. So using social determinants of health as a guide for discussions with individuals or guardians or caregivers to decide what services and interventions are the best fit. And this is really important. We had a lot of discussion around this with the collaborative. The idea here is that this isn't just a matter of saying to the patient, oh, you fit into this group, so we're going to tag you with this intervention and push you into this program. These are all options for patients and individuals. And it really, requires that the clinician have a conversation with the patient and say, I recognize that this seems to be an issue you're having, and here are some different options available to you to help you deal with this issue. And I think that that's a really important conversation that we need to think about. We're not just putting people in buckets and assigning them and pushing them into programs. Healthcare is personal, and it has to include a conversation with a patient saying, the same thing if you're a cancer patient, these are your treatment options. Which of these make sense for you as an individual, for your life and your healthcare goals and your quality of life goals? So again, it's not just a matter of sticking people into these programs, but it's really brings up an opportunity for a conversation with the patients, a good quality discussion with patients and individuals or caregivers or whoever it might be, educating that patient and saying, this could be impacting your health, your food issues or your transportation issues, seems like it could be impacting your health. So I think that that's a really important principle. We talk a lot about that in the paper and the background as well. And I want to make sure that we point that out because it's really an important piece there. And it seems like I've come to the end of our principles here. I do want to make sure that everyone is aware, and again, that we'll send that link out so that you can get that information. And I think there is a polling question here, Erin. So I guess if we want people to go ahead and answer that there. And I'm going to turn it over to the next person on the agenda. I think we'll be open to questions at the end.
Thank you, Jennifer. Thanks for providing an overview of the guiding principles. Before we move on to some real-world examples of how SDOH can and should be leveraged, we want to hear from our audience. So we have this question based on these guiding principles. We want to know which of the ethical uses are most critical to your organization. You can go ahead and start answering those live. We want to hear from you. Is it care coordination? Is it recognizing risk through SDOH analytics? Is it mapping community resources and identifying gaps, or service and impact assessment? Or is it finally customizing health services and interventions? Although all of these are important, we are interested to see, for the most part, which of these are most critical to your organization right now. So we have some results coming in. I'm going to go ahead and we'll push these out to you all so you can see where we see. Okay, so we see recognizing risk through SDOH analytics is taking the lead. Second to that is care coordination. And after that is mapping community resources and identifying gaps. Okay, it looks like 1 and 2 are kind of neck and neck with each other. And finally, a service and impact assessment and customizing health services and interventions. Interesting. So it's good to hear from the healthcare organizations that are on here, which of these are on your priority list. As we continue, and with that, I'm going to go ahead and pass the presentation to Karen Van Zant. She'll be taking on the next part of our agenda, which is giving us some real-world examples. Go ahead, Karen.
Great. Hello, everyone. This is Karen Van Zant. I am with CareSource. I'm the Vice President over our Integrated Community Partners Program, and I'm responsible for the overall strategy for social determinants of health here at CareSource. So I'm going to move the slides. You can go to the next one. Next slide. There we go. Next slide. Okay, so CareSource. Just 30 seconds about who we are. We are a nonprofit government managed care organization headquartered in Dayton, Ohio. We are in 5 markets: Ohio, Indiana, Kentucky, West Virginia, and Georgia, and have the privilege and responsibility to provide care to 1.8 million Americans across those 5 markets. We do have several products. The majority of our work is in the Medicaid space, but we are also in the health insurance marketplace. We have a Medicare Advantage plan and have a duals demonstration here in Ohio. We have employees located across the country and have had a lot of rapid growth in the last couple of years, which kind of leads me to how social determinants of health have been incorporated within our plans and within our markets, and a couple of examples of how we're utilizing social determinants of health data. Oh, there we go. Oh, all right. Okay, so our population health strategy, we have really looked at 100% of our population, and traditionally we have used clinical stratifications and clinical triggers to really identify those members who are at the highest risk, that are at rising risk, those that are most complex, folks who are very costly, and making sure that the costs associated with their care really align with the conditions that we're helping them to manage. And I started at CareSource 4 years ago, really trying to understand the role that community-based organizations play in the majority of our members' lives from a Medicaid perspective, and what kind of information was CareSource receiving, either from our state partners or from our health or community partners, around socioeconomic indicators in our members' lives. Kind of our premise around our membership is really helping members move to wellness, moving them to a high quality of life. And for a person who I was actually a Medicaid recipient, I've been a recipient of many safety net benefits, understanding that living at 138% of the poverty level, which is the Medicaid expansion level here in Ohio, is probably not the highest quality of life that some of our members, or most of our members, could achieve. And so we really started in 2015 with a pilot program here in Dayton, Ohio, around integrating socioeconomic factors for our members alongside of their clinical and behavioral health data that had a focus on education and employment, which was something that our members in Ohio told us would make a significant impact on their overall life, their overall health and well-being. And so I know if we go to the next slide, we started the division that I oversee, which is Life Services, and the first program or product to come out of Life Services is called Job Connect. And still, after 4.5 years, we get a lot of folks who ask us, why would a health insurance company get involved in workforce development? A very fair question. We've not found a lot of folks that are our partners or peers or competitors that are taking on workforce development. And really the answer to that question is we are not trying to take on workforce development. We're trying to assess the gaps in the various socioeconomic systems across the clinical systems that our members are interacting with, and convene and help coordinate and help leverage those various systems on the social side of things on behalf of our members. And so we actually made the decision with our Job Connect program. Our board gave me a clean sheet of paper and a small amount of money and said, really challenged me to think about how we leverage our clinical care management model that we had been utilizing and deploying here in Ohio for almost 27 years at that point in time, and build upon it the ability to really assess what was happening in our members' lives outside of doctors' offices or pharmacies or hospitals. And so I'm a social worker and I'm a community developer, have worked in workforce development programs and at the neighborhood level, really kind of understood that for folks that are at a certain federal poverty level limit and understanding the programs that are on the socioeconomic side of those members' lives, that for many of our members, they could be utilizing, in addition to the Medicaid program, 6 or 7 additional safety net programs in their lives that all have different requirements, different limitations, case management that looks different than our clinical case management, those types of things. And so as we built the Job Connect program, we wanted to make sure that we didn't duplicate anything that was already happening in our communities. So we wanted to leverage the community colleges, the Goodwill Easter Seals groups, the community action agencies, the Catholic social services, all of the folks that have traditionally done education or employment types of services for our members. But what we also wanted to do is make sure that those classrooms were full of members, that our members knew how to get there or had a way to get there, that they understood the restrictions around some of those programs, and that we really did what we did on the healthcare side, which was increase access and coordinate across multiple systems. Let the providers, the community-based providers, provide services, much like we let folks, our doctors provide services on the healthcare side, and then really start to aggregate the data and see if it would have an overall impact on engagement was the first thing, health and well-being was the second thing, and were we actually able to help members move into employment or employer-sponsored insurance. And so that all got kicked off in 2015, and we've had a great 4.5 years worth of learning as well as data collection. One of the things, and so you can see some of the things that make our program unique. Along the way, what we recognized is that the information that we as a plan receive from our state partners doesn't have a lot of socioeconomic data in it. And so, when we looked at the 834, there was a housing question, but there was only one housing question, and it was a closed-ended question of, do you have housing, yes or no? And when I would talk to the clinical staff or the folks at the Ohio Department of Medicaid, I said, well, what if somebody answers no? And they were like, well, that's the answer to the question. And so, the social worker in me was like, well, no one is going to have good health if they answer no to having housing. So that would be good for us to kind of figure out how do we continue to add questions or receive information around this. So in 2015, we added socioeconomic questions to the health risk assessments, got permission from our state partners to ask members in a voluntary way to give us information on what was happening on the socioeconomic side of their lives. For any of you that are on from plans that are on this call, you know that it's sometimes hard to get members to engage in their health risk assessments or engage in surveys or CAP surveys, those kinds of things. And so as information slowly started coming in first person from our membership, we then kind of decided that we needed to start to consume public data sets on the social side of the coin so that we could add that to the clinical information that we have from our states. And as we started doing that, we really saw a different stratification of our members, and we really were able to start filling in some of those questions as to why members were high utilizers or were being readmitted into the hospital or, weren't filling their medications on a regular basis. And so we've been in partnership, I guess in all transparency, I should say I was a part of the group that worked with eHealth on the recommendations, and I'm also a customer of LexisNexis, and we've been in partnership with Lexis for a little over 3 years now, really kind of thinking through the use of social determinants of health data, how we consume, not just consume the data to analyze it or to make strategic decisions, but how do we really consume that data to put into operations so that it changes the way in which we care and deploy care for our members. And so if you go to the next slide, kind of the proposed use cases that we are currently working on with Lexis fall into these 5 buckets. You're really looking at the motivation and engagement score. If we have a percentage of our population that's completely disengaged. They have access to health care, they have a CareSource card, but we're not getting anything on a claims system, we're not getting anything from contacting the member or any kind of interaction with that member. And we always have that question of why. If a member has access, why aren't they utilizing the access? What might be the barriers to them utilizing their access, and how might we be able to fill? I mean, we know that the only way to truly help any one of us to manage our own care is if we're engaged. And so this motivation, the likelihood to be to get a person who's disengaged engaged really helps us to look through that entire list of disengaged folks and target our resources to those folks that would have a higher motivation score. And that's really kind of how the indexes work, is we kind of get a stratification across these 5 different buckets as we add the information to our members' lists and can then pull and put strategies as well as different work paths in place for our customer advocacy groups, our care coordinators, our life coaches, so that we truly can target care to those that are most in need. And so I thought I would just kind of give you a snapshot of how the social determinants of health work data and the work of our life coaches in our Job Connect program actually looks from a member's perspective. So this is an actual member story. We have changed his name, although he has a YouTube video out there, and he's very proud of the work that he has done with his life coach and all of the changes that have happened in his life, and has given us permission to kind of share some of his story. And so we have been working with him almost 18 months now. He called in. He looked at the 800 number on the back of his card one evening. He was severely intoxicated and called our customer advocacy line to get help. And he didn't even know what kind of help he needed. He doesn't remember much about the call. But through the assessment, not only did we help get him coordinated with some behavioral health services, but we got a lot of information in the notes from that one call around the fact that Juan did not have a high school diploma. He had lost his driver's license to a DUI. He was working part-time, but the hours were inconsistent and his transportation was inconsistent, so he had lost multiple jobs. And he really wanted to start to get his life back on track. He had notified the customer advocate that his drinking had escalated when he lost his driver's license, and it had gotten out of control, and that he felt like the only thing he needed was a job. And so through that, we got him referred to treatment program and to our life services. And through care coordination and through the life coach's interaction, they really helped him to determine what he wanted his action plan to be. And I think that this is really critical. It's also one of the points that Jen pointed out from kind of the ethical uses of data is we are very strong believers that each one of our members need to be the leader in their lives, and they need to have their own self-determination and to identify their own priorities, and we need to kind of follow their lead in helping to coordinate care, whether it's on the socioeconomic side, on behavioral health, or on the clinical side. And so there would have been a lot of things from that. I think it was a 6-minute phone call that we could have done outreach to Juan and said, here's all the things you need to do. When you finish this list, call us back. But it doesn't go that way with the members here at CareSource. And so these 4 bullets are the things that actually, it was the first 2 bullets that he stated right away that he wanted to work on when he met with his life coaches. He knew he needed to get into a treatment program. He had been in treatment previously, about 5 years earlier, and had maintained sobriety for a period of time, and then kind of relapsed through that. And he knew that he wanted to go through that process again. And as they talked about the part-time job with inconsistent hours, he recognized that he had very limited options because of his educational background. And so instead of jumping into a better job or another part-time job, he was going to maintain the part-time job that he had and start working on his GED. And that relationship, that follow-up meeting happened within a week of the first call. There was a follow-up call within a couple of days and a time scheduled based on his appointment, and that meeting took place. And what we like to say is the rest is kind of history, is that life coach has continued to work with him with regular touch bases. Sometimes those touch bases happen in person, sometimes they're text, sometimes they're phone, sometimes they're emailing back and forth. And what we've seen is the progress that's happened in Juan's life because of the actions that Juan is taking and the ways in which the life coach is just making suggestions or helping to connect him with resources that are a part of the care plan that he has. We've had over 4,000 members in 3 states, Ohio, Indiana, and Georgia, who have participated in our Job Connect program with a life coach. And what we've seen is about 40% of them do go into an employment opportunity that was better than the one they came with, or if they came unemployed, actually has moved them into an employment situation. And of those that are moving into employment, 85% of them are retaining their employment at 90 days. Our life coaches do follow folks and continue to help them because as we all know, life happens. Just because you begin a job doesn't mean that everything goes as planned, and life happens. We also want to make sure that as folks start to as their income starts to raise and they may lose other safety net subsidies, that we're there to help them navigate the subsidy cliff. And so one of the parts of our program is that their participation is not tied to their Medicaid eligibility past employment. We stay in that voluntary relationship with them for up to 2 years. From a clinical perspective, as we've assessed social determinants of health data and taken the approach of helping to coordinate care on the socioeconomic side, we have seen a reduction in ED utilization of 20%. We have seen a decreased outpatient spend of 22%. And interestingly enough, we've seen an increase in our pharmacy spend of 16%. And as we dove into the types of prescriptions and the folks that were starting to fill their prescriptions after working with a life coach, what we found was a little bit shocking. The first piece of information is we found that members knew they needed the prescriptions before they engaged with life services, but they weren't filling their scripts for whatever reason. But it wasn't as if they just started utilizing the healthcare side of things and they were newly diagnosed with things that would require a prescription. So a significant portion knew they needed the medication beforehand. The other thing that we found in the data is of those that were filling the scripts at a higher level, 40% of them had SMI and SUD diagnosis in their background or history. And so really helping them to connect the dots to the socioeconomic goal or the education or employment goal and connecting that back to the behavioral health and the medication goals, we feel has been a very good benefit to our members, and that's the kind of increase in pharmacy spend we want to see. And so this is, as of today, this was a few months ago. One is actually at 16 months worth of sobriety. He's got his driver's license back. He's got a full-time job working at $14 an hour. He's continuing to complete his GED and high school diploma. He's definitely struggling with that. Particularly the math section is giving him some trouble, but he wants to complete that because he's articulated a career goal of working in the HVAC field and understands what a boost that would be for him and his family. So that's kind of the real life work. We have a lot to learn and are continuing to learn. We have pilots that are starting in the housing realm and in the food access realm, but we have a lot to learn about what we need to do with social determinants of health moving forward. So I think we have another polling question.
Thank you, Karen, for sharing your experience and successes with implementing SDOH data and analytics in the workflow. You also shared some use cases you're exploring to further advance your organization's efforts to leverage SDOH in more areas, and we also want to hear from our audience. So we have this question up. Which of the following would you be most interested in knowing about a patient? Would it be the likelihood for them to be readmitted, the likelihood to adhere to medications, the risk based on total predicted healthcare costs, the motivation to care for one's own health? Looks like some of our answers are coming in. Go ahead. We'll give it another minute. You can go ahead and let us know which of the following areas would you be most interested in knowing about a patient. Interesting. Okay. It looks like number 4 comes in the lead, the motivation to care for one's own health being the primary area of interest, and second of all, the risk based on total predicted healthcare costs. That one is followed by the likelihood to be readmitted, and fourth is the likelihood to adhere to medication. Interesting. Motivation came in the lead. So you can all see the results that are posted here. We also want to take these different areas of interest that you have and also explore what's the right type of data and analytics that you would need in order to power these insights. So with that said, we're going to go ahead and turn this over now to our next speaker, which is Erin Benson, and she'll go ahead and share with us the right data and analytics to power those insights.
Charlene. So I just have a few minutes left today, but for this last part, what we wanted to talk through was really related to one of those key guiding principles that Jen had mentioned around using social determinants to create analytic tools to predict future health outcomes. So basically, we believe that by understanding who's likely to be at risk for certain health outcomes, like medication non-adherence and readmission, that healthcare organizations can be proactive in helping these individuals achieve better outcomes. But in order to do this and to get the most use of those analytic tools, it really starts by having the right data sets. And we've seen an evolution of this occurring over time. So if we look at some of the early stages of trying to use social determinants of health, there were some key pitfalls that we saw. Initially, organizations tried to use community-level data. So this looked at insights about a member's neighborhood, but it really missed other categories that were impacting the member, things that you saw before from Jen, like education and their social context, as well as things like their financial situation. Also, while some neighborhoods are homogeneous and you can assume certain things, other neighborhoods have a vast difference in urban areas where you might have luxury condos next to Section 8 housing. So this became a challenge where we really wanted to drive down to the individual level to best improve care. After trying at the community level, other sources were brought in that were non-clinical data, but a lot of these were targeted at marketing use cases, and so they weren't clinically validated against health outcomes, and their fill rates and match rates tend to fluctuate a lot. So this made it difficult to build any kind of predictive models on a consistent basis. This also meant that organizations were spending a lot of time up front just trying to wade through that data. So these early attempts really taught us two critical lessons. The first was that the quality of the data that provides those insights really does matter. Data to be used in any social determinants of health exercise should come from extensive sources of data, including marketing, public records, credit, and consumer data. Any source really that can paint a comprehensive picture and provide insights into a member holistically, including all of those categories that we mentioned before, like economic stability, education, neighborhood, and social context. It should also provide information about the individual and their surrounding network, because we know who your relatives are, and household situations can also have a vast impact on your ability to have positive health outcomes. And most importantly, all of those elements should correlate to health risk, so that we're spending time building meaningful predictive models and not having to wade through data dumps. The second lesson that we learned was that analytic groups and care management groups within organizations really need to work together to integrate social determinants insights into workflows. Targeted action really needs to be taken for health to improve, and you heard a lot of those examples from Karin. So we've summarized our recommendation for process around using social determinants into 3 steps. Basically, you start by using predictive models to identify members and patients who face health barriers to improving or maintaining their health. Then those factors can be turned into scores that can be used to understand the severity of that risk for each member, and that helps to prioritize outreach. And then third, care management teams can provide insights about how to approach individuals based on those individual social determinants needs and their relative risk. At that point, they should be having conversations with the patient or member in order to help them. That helps to lead to prioritized outreach. So there were several examples that we could walk through. There's a lot of different areas where we see correlations to social determinants of health. We see it with address stability, healthcare literacy, education, but I want to dig into just a couple examples where our data scientists have gone and found the clinical validation and correlations between some of these key health outcomes and these social determinants. So the first example we have is that social isolation is related to medication adherence. Social isolation can be predicted based on proximity to nearest relatives and associates, marital status, number of people in the household, and similar types of attributes that you can find in public records data. Social isolation and loneliness have been proven to put individuals at greater risk of things like cardiovascular disease, dementia, depression, and anxiety. And one specific correlation we found is that our data scientists noted that members who have relatives or associates that live less than 25 miles away from them are more likely to adhere to their medications than those whose nearest relative lives farther away. Given this impact of social isolation on health, actions can be taken to get those individuals into support groups or arrange for more frequent follow-up calls as a way of improving their overall health. Another example we have to show the correlation is related to economic stability. So our data scientists found that a correlation between readmission to the hospital within 30 days of an inpatient hospital stay correlated to the sum of tax-assessed values for all properties that that member currently owns. The correlation showed that individuals who are the same age but have higher average property values are less likely to be readmitted to the hospital than those who have lower average property values. These are just a few examples among hundreds of the ways that socio data can improve predictive modeling that can better enable that proactive care management. So that leads us to our last poll question for the day. The question is, has your organization committed resources to investigating and or implementing the integration of social determinants of health into your existing operations? And your possible answers are yes, no, this is a new or near future opportunity, or you're not really sure what your organization is doing around this today. We'll give you a couple seconds to respond. Well, the good news is about more than half the audience is saying yes, this is an area that their organizations are looking to invest. That's fantastic to see, and we hope today's presentation has given you some great principles to employ while you're starting to think about how you put those programs in place, as well as examples and some thoughts around the data sources that you may want to utilize. So with the few minutes that we have left, I'm going to turn it over to our moderator to open it up for questions.
Thank you, Erin, for sharing. It looks like we have quite a few questions that have come in from the audience, and we may not have time to answer all of them, but we will do our best here to get through at least a few of them. Here we go. Let's try this one. Are there any good examples of how organizations have tracked referrals to community resources? We can open this up to the speakers.
Yeah. Karen, I think, Karen, we discussed a few different examples of this when we had the collaborators meeting. But, yeah. Karen, do you know of any specifics that you could mention?
Yeah, so we actually, here at CareSource, we track all of our community referrals. We are partnered with Aunt Bertha and their community resource tool. It is in the process of being embedded into our clinical care management system to do two things. One, we are hooking the PREPARE assessment, the social determinants of health assessment that was developed by the CDC, to our health risk assessments that the states have asked, that mandate that we complete. And then based on the answers to the social determinants of health questions, Aunt Bertha is working with us to be able to link the community resources in their system within the care management portal. The closed loop on that is still in process, but we have a lot of great partnerships with our community-based organizations and with our members who will tell us that they've received services, and we have been tracking what we call wins in our system. Those wins, when we get feedback from our community-based organizations or from our members, so that we can really start to identify who the top community-based providers are in each one of our geographic regions.
Erin, I noticed we got a lot of questions around consent, and when I just wanted to make a quick comment on that. I know we don't have a lot of time, but there were a lot of questions about whether or not it'd be appropriate to discuss interventions with a patient. And I just want to be clear, we were very, the group was really emphasized that patient consent was really necessary for all of these things, and without trust and patient consent, that it wouldn't be appropriate or ethical to do these things. So that was at the forefront, I think, of our minds when we were thinking about intervention with SDOH, that all of this really had to be very transparent to the patient and something that they had agreed to.
Thank you for wrapping that up. There were quite a few concerns, so I'm glad that you addressed that. We are pretty much at the end of our time here. But those of you that have entered questions, we will be reaching out to you as well via email. We want to thank you for joining our presentation. And this will conclude today's presentation. We thank you for your time. Please watch our follow-up communication where we will be sending you the deck and the recording from this. And hopefully you can share it out with any of your colleagues that may have missed it as well. Thanks again, and we look forward to having you join us for our next one.